we have discussed about how to approach for renal pathology with the help of immunofluorescence and electron microscopy. Now we are going to see about some of the important nephritic syndromes, right? So now we are going to discuss about nephritic syndrome. So our next topic is the nephritic syndrome. In nephritic syndrome, number one, we are going to discuss about is the disorder which is also known as PSGN, post-streptococcal glomerulonephritis, right? So this disorder is also called as post-streptococcal glomerulonephritis. Post-streptococcal glomerulonephritis, because initially it was found to be associated with streptococcal infection. That is why the name has been designed as a PSGN. But at present, this name is also associated with many other infections. So that is why the name has been changed. So the new or latest name is acute proliferative glomerulonephritis. Acute proliferative glomerulonephritis. So this is the name which we are using currently, or we are using for recently, right? So this point also we have to take in our mind, because this name was used in All India exam 2016, right? Acute proliferative glomerulonephritis is most commonly caused by streptococcal infection, right? So what is the important features? What are the important features in case of post-streptococcal glomerulonephritis or acute proliferative glomerulonephritis? Number one, it will be affecting children predominantly, right? So it will be children who will be averaging from 5 to 15 years, right? So majority of the cases will be a pediatric age group, 5 to 15 years, but that does not mean that only children will be affected. We must remember that adults may be affected in this disorder, right? So may be affected by this disorder, they are adults also, right? So it is a pediatric age group, and this will follow streptococcal infections, right? So as the name suggests, streptococcal infection. So they are secondary to streptococcal infection. Which streptococcus? Group A beta hemolytic streptococci, right? So these are group A beta hemolytic streptococci, right? So group A beta hemolytic streptococci, what kind of infections? So it is both pharyngitis and impetigo, right? So skin infection as well as sore throat. So pharyngitis means sore throat. So it is secondary to pharyngitis also, and it is secondary to skin infection also, right? It is secondary to skin infection also, which is called as impetigo, right? So both can lead to the PSGN. So this point we have to understand. PSGN is due to both sore throat as well as skin infection, which is called as impetigo, right? So that is very important. So in this case, when there is a pharyngitis or sore throat, there is an interesting feature regarding incubation period. Whenever there is a pharyngitis, see what I am writing here. Whenever there is a pharyngitis or sore throat, this will be followed by hematuria. So patient will be coming with pharyngitis history. After some time they will be developing hematuria, right? So after some time they will be developing hematuria, and because of hematuria, urine will be appearing like a cola colored urine. So in exam, examiner may write the baby is having cola colored urine, right? So cola colored urine will be passed by the patient, right? So from the pharyngitis to the hematuria, there will be a time period, there will be a gap of time. What time? That will decide the etiology also. So when we are seeing a patient of the pharyngitis and they are developing hematuria after 1 to 3 weeks, right? So always keep that in mind. After 1 to 3 weeks, this will be suggestive of post-streptococcal glomerulonephritis. So that is the important point we need to understand. One of the very important things to notice while doing the clinical examination, when a patient is having hematuria after pharyngitis, that is after 1 to 3 weeks, we will think about which disorder? PSGN due to streptococcal infection. And when this timing is, remember, when this timing is 1 to 3 days, see this, 1 to 3 days. So 1 to 3 days of the timing will be suggestive of IgA nephropathy. IgA nephropathy, right? So that is very important to understand how to differentiate IgA nephropathy from the PSGN on the basis of the incubation period between pharyngitis to the hematuria, right? So 1 to 3 days will be suggestive of IgA nephropathy, 1 to 3 weeks will be suggestive of PSGN, right? So it's done. But what can be the future question? That is important. What can be the future question, right? So now we will see how question will be asked to you in your exam, right? If patient is having recurrent hematuria, remember, if examiner is saying there is an episode of recurrent hematuria, then it will be more suggestive of the IgA nephropathy, right? So when examiner says recurrent hematuria, we will think about IgA nephropathy, right? And when examiner says ki there is a single episode of hematuria, because after the infection they will develop immunity against the infection and there will be no hematuria afterwards. So single episodes of hematuria, if you are seeing in the history, that will be suggestive of PSGN, right? So when examiner says pharyngitis followed by recurrent hematuria, most likely IgA nephropathy, All India 2014, right? Same way, if examiner says pharyngitis followed by single episode of hematuria, that will be suggestive of the PSGN. Another type of presentation which examiner may ask: a child 15-year-old was having pharyngitis, he has developed hematuria and his complement C3 level were normal. Then what will be your diagnosis, right? So here we must understand there are two type of languages which examiner can use. C3 level was normal. Second language, C3 level became normal after 2 months. Then what will be your diagnosis? So these are the two questions which are very close and language based MCQ. When examiner says C3 level is normal, C3 level is normal, C3 complement level is normal, that will be in favor of IgA nephropathy. And when examiner says C3 level is normal after 2 months, because initially C3 will be decreased, right? In PSGN, complement C3 level will be decreased, and after 6 to 8 weeks, remember this point, after 6 to 8 weeks, which is approximately 2 months, right? Which is approximately 2 months, it will become normal, right? So after 6 to 8 weeks, it will become normal. So that is why we think about it as PSGN, right? So when examiner talks about C3 level was initially decreased and then it became normal, that will be suggestive of PSGN. So that is how we have to distinguish PSGN from the IgA nephropathy, right? Now we will see how examiner had asked earlier question. This question had been asked as a transient hypocomplementemia. Transient hypocomplementemia is a feature of PSGN, right? So that point we have to keep in our mind. So this is how we are going to differentiate, right? So now we can see this is how we are going to differentiate the IgA nephropathy from the PSGN on the basis of three things. Number one, incubation period 1 to 3 days, IgA nephropathy, 1 to 3 weeks, PSGN. Recurrent hematuria, suggestive of IgA nephropathy. If single episode, suggestive of PSGN. If C3 complement level is normal, IgA nephropathy. If C3 complement level is transiently decreased for 6 to 8 weeks, that will be suggestive of PSGN. And always remember this point, 6 to 8 weeks. This was the question in DNB exam 2015. So can be your future question in All India exam also, right? Now we will see approach. As I said, whenever we are going for diagnostic approach for renal disorder, we rely on three things: light microscopy, electron microscopy, immunofluorescence microscopy, right? But here, because they are having a streptococcal infection, so we will be taking support of the serology also, right? And in serology, what we are going to look for? In serology, we are going to look for two things. One is the anti-streptolysin titer, anti-streptolysin O titer, right? Which is also called as ASO titer, right? So ASO titer is the number one thing which we rely on, and second thing which we follow or which we try to see is anti-DNase antibody, anti-DNase antibody. So these are two things, right? These are two things which we use for the diagnosis of any PSGN disorder. Right, there was a question in All India Exam 2014. Out of these two, which of the following is the most important or most diagnostic or most relevant or best one? So remember, if examiner says which is the best one, your answer must be anti-DNase antibodies are always superior to the ASO titer, and that was the question in All India Exam, right? So anti-DNase antibody is always superior to the ASO titer. That is also one question, and we have to keep that in mind, right? Now coming to the examination, microscopic examination, when you will see the light microscopy, what will be the features on the light microscopy? When you will see the renal biopsy, glomeruli, what will be the stature of the glomeruli at this moment? Glomeruli will be hypercellular because of the infection and proliferation of the inflammatory cell. So that is hypercellular glomeruli. So glomerulus will be appearing to be hypercellular. And what will be characteristic of this glomerulus? What will be characteristic of this glomerulus? Hypercellularity. Why there is a hypercellularity? And now we will see. This hypercellularity is because of both endocapillary as well as exocapillary proliferation. Endocapillary as well as exocapillary proliferation. Endocapillary and exocapillary, both type of proliferation will be there. Hypercellularity is because of endocapillary, exocapillary proliferation, right? So now we have to understand both types of proliferation will be there, right? Both types of proliferation will be there. What do you mean by endocapillary proliferation, exocapillary proliferation? So that we can understand by a simple diagram which I am going to show you here. Right, suppose this is the glomerular capillary. I am just showing you a schematic diagram. This is the glomerular capillary endothelial lining. Right, when you are seeing inflammatory cells, inflammatory cells are getting increased inside the capillary, that is called as endocapillary proliferation. And when you are seeing outside the capillary into the mesangium, when you are seeing inflammatory cell outside the capillary in the mesangium, so these are mesangial proliferation. These are mesangial proliferation of the inflammatory cell. So this will be called as exocapillary proliferation, right? So now we can understand exocapillary, endocapillary, what does it mean? Within the capillary, proliferation of endothelial cells, inflammatory cells will be called as endocapillary, within the capillary, endo, and when they are outside the capillary, they will be called as exocapillary proliferation. So both endocapillary and exocapillary proliferation will be seen in this disorder, right? So that is the importance of the light microscopic view of the PSGN, right? Now we will see what will be the finding on electron microscopy. When you are seeing electron microscopy, first we should understand what was the basic pathology of the PSGN, right? Basic pathology of the PSGN is because of the infection, there are formation of immune complexes. So what I want to say that PSGN is a immune complex mediated glomerulonephritis, right? If they are immune complex mediated glomerulonephritis, tell me what type of hypersensitivity reaction it is. It is type 3 hypersensitivity reaction. So that is also important question we have to keep in mind. right? So it is type 3 hypersensitivity reaction, immune complex mediated glomerulonephritis, where immune complex will be deposited at what place? At what place, right? So again, I will show you the same thing which I have described when I was showing you the glomeruli and capillary. See what I am showing you. This is the Bowman capsule. Parietal epithelial cells, right? So these are parietal epithelial cells. There are urinary space, and below this, now you can see there is a capillary lined by endothelium. So capillary is lined by endothelium, supported by basement membrane, and there are cells which are having foot-like process, right? So what are these things? These are the podocytes. So these are the podocytes, right? So this is podocytes or visceral epithelial cells, right? Visceral epithelial cells, which are also known as podocytes, right? P for podocytes. So visceral epithelial cells, podocytes. So now we are seeing again the electron microscopic view of a renal biopsy, right? In that renal biopsy, we are going to look for the deposits. Where will be deposits? So deposits will be dark black color. So I am making it with black, and they will be the large deposit like this. So there is a large immune complex deposit. So this deposit is large, and what is the location? Below the visceral epithelial cells or podocytes food process. So this will be having subepithelial deposits. Subepithelial deposits. So subepithelial deposits are the most common type of deposits seen in PSGN. Most common type in PSGN is subepithelial deposit, and that was the older question in All India exam. Subepithelial deposits are seen in case of PSGN. So in PSGN, most common type is the subepithelial deposit. That was the question, right? So why I wanted to tell, because there was a question in PGI exam, older PGI question, what kind of deposits you will see in PSGN. See the language, what kind of deposits you will see in PSGN. So that time all type of deposits were right answer, because all type of deposits will be seen. What? All types of deposits will be seen, but most common is the subepithelial. So I wanted to draw this, all type of deposits, intramembranous deposits, subepithelial and subendothelial deposit. So this will be subendothelial deposit, and inside the mesangial matrix, that will be mesangial deposits. So all type of deposits will be seen in PSGN. That was the question in PGI exam, and that is what I wanted: intramembranous, subendothelial, mesangial. But when examiner talk about which is the most common, subepithelial is the most common type of deposits, right? So that is the electron microscopy of the PSGN. Now we will see what will be the immunofluorescence microscopy. On immunofluorescence microscopy, as we all know that it is immune complex mediated. So as we all know that it is immune complex mediated disorder. So now you tell me what kind of presentation you are going to expect in the glomerular capillaries. I am enlarging, and just recall what I have said in the discussion of the immunofluorescence microscopy. Three types of, right? Antibody mediated, immune complex mediated, and band pattern, right? So when you are seeing immune complex mediated, you will be seeing granular deposits like this. You will be seeing granular deposit like this, and this is called as granular immunofluorescence. So you will be finding granular pattern of immunofluorescence. So granular pattern of immunofluorescence will be seen in case of granular pattern of immunofluorescence will be seen in case of PSGN, right? So that is the important thing which we have to keep in mind regarding this one, right? Now I will show you the electron microscopic view of these PSGN. Now look at this picture. When you are seeing this diagram, right, as I had explained you earlier also, this is the electron microscopy of the glomerular capillary, where we are noticing these outline which I am going through is the podocyte, right? So I'm showing you these are the podocytes, their food process, and suddenly you see this homogeneous gray, see homogeneous gray mass, and these are subepithelial deposits, right? These subepithelial deposits are very big on electron microscopy, looks like a hump, and that is why they are also called as subepithelial hump. That is why they are also called as subepithelial hump. And examiner asks question, which of the following disorder you will see hump sign, right? So hump sign is diagnostic of hump sign, electron microscopy diagnostic of PSGN, right? Now look at the immunofluorescence microscopy. As I said, on immunofluorescence microscopy, look at these areas, and what you are observing, all these are yellowish green granular immune complex deposit, right? So what type of immunofluorescence we are observing? We are observing granular immunofluorescence. So granular immunofluorescence, because of immune complex pathology, PSGN will be showing granular immunofluorescence, right? So we have seen electron microscopy, there is a subepithelial deposit most commonly, and immunofluorescence because immune complex mediated, so granular pattern of immunofluorescence will be visible. Coming to the prognosis of this disorder, prognosis is usually good in this patient because chronic renal damage or chronic renal failure, CRF, right? Chronic renal failure is least common in which disorder? Answer is PSGN, right? So PSGN usually they resolve in acute phase itself. Chronicity never develops, or not, I should not say, just remove this. CRF is least common in PSGN because mostly they will resolve in their acute phase itself. Very rarely they will be going for the chronic renal failure, right? So least commonly going for CRF will be PSGN. So here you can mark one more future question which examiner may ask in future exam. Okay, what will be the most common cause of chronic renal failure amongst the glomerulonephritis? So when we are talking about glomerulonephritis, what should be the most common cause of chronic renal failure? And your answer should be rapidly progressive glomerulonephritis. RPGN is the most common cause of chronic renal failure, right? So this is about PSGN. Now we will see the another disorder which we have compared just now, that is called IgA nephropathy, right? Just now we have discussed some salient features. IgA nephropathy is also known as Buerger's disease, B-E-R-G-E-R, Buerger's disease, right? So this is also called as Buerger's disease. So this second name also we must keep in mind, Buerger's disease. It should not be confused with the Buerger's thrombophlebitis, right? So there is a one disorder, this spelling is Buerger's. Buerger's disease is the vasculitis, right? So it is different, right? So it is also called as thromboangiitis obliterans, and these are vasculitis. See the spelling B-U-E, and here it is B-E-R. So Buerger disease is IgA nephropathy, and this IgA nephropathy is commonly seen in pediatric age group. Again, we can see this is the pediatric age group disorder which will be affecting 5 to 15 years of age group. That is why it was considered as closer differential of the post-streptococcal glomerulonephritis, right? So these are Buerger's disease, pediatric age group, and they are the most common type of glomerulonephritis. So most common type of glomerulonephritis, as you remember, we have discussed in nephritic syndrome what is the most common cause. Answer was IgA nephropathy, both adult and overall, right? So that point we have to keep in mind. This is for both adults and overall. So adults and overall, this is the most common cause of glomerulonephritis, right? And remember here, another important feature, they are the most common cause of hematuria also. So they are the most common cause of hematuria also. What kind of hematuria? All kind of hematuria, means gross also, microscopic also, right, and recurrent also. So whatever episodes of hematuria you are seeing, you must think first about IgA nephropathy. So IgA nephropathy is the most common cause for gross microscopic as well as recurrent hematuria, right? When you are seeing the pathology, what is the pathology of the IgA nephropathy? It is due to pharyngitis, right? So in here, pharyngitis will be usually by viral infection, not like streptococcal, right? So pharyngitis is due to viral infection. They may be associated with autoimmune disorders like celiac disease, GIT infections or inflammations like hepatitis. So these are the some of the reason for the development of IgA nephropathy. Pharyngitis, celiac disease, hepatitis, all these things can be the reason for the development of IgA nephropathy. Means when a patient is suffering from this, he will also develop hematuria or cola colored urine after 1 to 3 days. That is important, right? So patient will be presenting with pharyngitis. So here, suppose I am telling you this patient was having pharyngitis, right? And after pharyngitis, he has developed hematuria, right? So after pharyngitis, he has developed hematuria. Already we have discussed. So I will be little quicker here. And that duration was 1 to 3 days. So that is why we are suspecting about IgA nephropathy, right? So IgA nephropathy, in IgA nephropathy, what are the things you will find? Right? What is the reason? So we were talking about pathogenesis, right? So pathogenesis is because of which immunoglobulin? Because of IgA immunoglobulin. IgA immunoglobulin is in excess, right? IgA immunoglobulin is in excess, and that is the reason for the damage of the mesangium. So how IgA will be damaging? Because this IgA is usually the mucosal secretions, right? These are the mucosal secretions. And when mucosal secretion occurs, they will be having two forms or two isotypes. There are two isotypes, IgA1 and IgA2, right? So now I am showing you two isotypes of the IgA. So these are the isotypes of the IgA, IgA1 and IgA2. Now the future question will be, which is nephrogenic, means which will cause IgA nephropathy. In simple words, which will cause IgA nephropathy, IgA1, IgA2, or both? So what should be the answer? IgA1 only, right? IgA2 is soluble and they will not harm anything. Only IgA1 is causing renal pathology, right? So IgA1, only IgA1, not the IgA2, right? Only IgA1 is associated with IgA nephropathy. So this point we have to keep in mind. IgA nephropathy is associated only with, remember, only with IgA1, right? So this will be only associated with IgA nephropathy, and where they will be having deposition. So what will be the site of deposition? Another important and very frequently asked question in exam. It is seen in mesangium. So they will be having mesangial deposits. They will be having mesangial deposits. So mesangial deposits will be seen in case of IgA nephropathy. And what are the deposits present in mesangium? So remember, IgA is the predominant, and especially IgA1. Apart from this, remember, they will be having IgG also, IgM also, and C3 complement level also, right? So these are the deposits. See, we all know about IgA1 is present in this mesangium, but what we have to understand, these were the older PGI question. What are the mesangial deposits in IgA nephropathy? IgA1, IgG, IgM. So all will be having deposit, right? So all will be having deposit. Even complement C3 will be having deposition. But what is important to understand, this C3 complement level will be normal in case of IgA nephropathy, right? When you are seeing the light microscopy, what you will observe? You will observe there is a mesangial hypercellularity. There will be mesangial hypercellularity, right? On electron microscopy, when you will see electron microscopy, what you are going to observe? On electron microscopy, see this again, I will show you. Suppose this is the capillary endothelial lining, right? Basement membrane and podocyte, right? So where will be deposits? So now we can see deposit on electron microscopy will be in the mesangium. So now we can see these are the mesangial, not inside the capillary, inside the mesangial matrix. So they will be having mesangial deposits, right? So they will be having mesangial deposits, and same thing you will see on immunofluorescence microscopy also. Immunofluorescence microscopy also you will find they are having mesangial deposit. This will be looking like this when you will be seeing the capillaries. So capillaries will not be having deposits, right? So their deposit, green color deposits will be, they will be having accumulated patchy deposit. These are mesangial deposits. So now you can see, you can correlate, this will be in the mesangium. So they will be having mesangial type of deposit. So now you can see on electron microscopy what we are observing, right? On electron microscopy we are observing, see the same thing we are seeing here, the capillary lumen, right, the basement membrane, and when you are coming outside the capillary, see outside the capillary, so here from here onwards it is outside the capillary, and in this outside capillary area you can see the grayish deposits here, right? So these are mesangial deposits. These are mesangial deposits. So mesangial deposits are present on electron microscopy, and when you will observe the immunofluorescence microscopy, beautiful picture where you can see the glomeruli and you can see yellow, this yellowish deposits are the mesangial areas, right? So you can see patchy yellowish deposits. So this will be mesangial deposits of the IgA nephropathy, right? So this will be mesangial deposits of the IgA nephropathy. So whenever examiner shows a picture like this, right? So you can expect this kind of MCQ in your exam, right? Look at this picture where you are seeing mesangial deposits on electron microscopy, and you are watching a mesangial immunofluorescence yellowish green color deposit like this in renal biopsy. So that will be suggestive of IgA nephropathy, right?